Hi, I'm Dr. Tom Buchholz. I'm a radiation oncologist, and I'm the medical director of Scripps MD Anderson Cancer Center in San Diego, California. I welcome you to our discussion of breast cancer cases today. We really have an outstanding multidisciplinary panel, including breast surgical oncology, breast medical oncology, breast radiation oncology, and breast imaging or breast radiology. And I'd like each of our panelists to please introduce ourselves. Let's start with Dr. Mamounis, our breast surgical oncologist.
This is Terry Mamounis. As Tom mentioned, I'm a breast surgical oncologist, and I'm the director of the Comprehensive Breast Program at the Orlando Health Cancer Institute in Orlando, Florida.
Thank you, Dr. Mamounis. Dr. O'Shaughnessy.
Hello, everyone. I'm Joyce O'Shaughnessy. I'm the Celebrating Women's Chair in Breast Cancer Research at Baylor University Medical Center and the Chair of Breast Cancer Research in the U.S. Oncology Clinical Trials Network in Dallas, Texas.
Thank you, Dr. O'Shaughnessy. Dr. Shaw.
Hello, I'm Chirag Shah. I'm a radiation oncologist at the Cleveland Clinic and serve as the Director of Breast Radiation Oncology and the Director of Clinical Research.
And the final member of our panel is Dr. Butler.
Hello, everyone. I'm Dr. Rennie Butler. I am Associate Professor at Yale University School of Medicine and Diagnostic Radiology, and I specialize in breast imaging.
Thank you, Dr. Butler. So our first case is a 65-year-old African-American female who's postmenopausal and has a history of ductal carcinoma in situ that we'll be discussing. Her disease is ER/PR positive, and she's been treated with a lumpectomy with negative margins. And two of the relevant questions that we're going to be discussing concerned what should be the radiation approach for this patient, and also consideration of endocrine therapy. So a little bit about her history. She just presented with routine screening mammography. She was asymptomatic. She had no family history of cancer or other cancer history. The diagnostic workup initially included a screening mammography that showed an abnormality that we'll be looking at in the upper outer quadrant. She also had a negative chest X-ray. She subsequently underwent a stereotactic biopsy revealing ductal carcinoma in situ, low nuclear grade. A month subsequently, she underwent a lumpectomy. The DCIS measured just slightly less than a centimeter in greatest dimension. It was an intermediate nuclear grade with a solid component and a cribriform component. The surgical margins were negative. On immunohistochemistry staining, ER was greater than 50% and PR was 50 to 10%. So we'll first turn to Dr. Butler and review with her some of the positive mammographic findings. Dr. Butler.
What we see here is two zoomed images from the left upper outer quadrant that show some calcifications. And granted, these are very fine findings that are difficult to see, but they can be seen quite well on a workstation in clinical practice. And when we evaluate calcifications, we assess both their distribution and their morphology. These calcifications have variable shapes and sizes, which raises the level of suspicion. And just as importantly, they're oriented along a linear axis, which suggests that they may have a ductal distribution, also raising suspicion for ductal carcinoma in situ.
What are features in mammography that would be predictive of being a non-invasive process or an invasive process? Can you predict from these findings the suspicion of having an invasive breast cancer versus non-invasive?
We can never be sure, but we can predict with some level of confidence that when we see only calcifications, it's much more likely to be a process that's confined to the ducts, as opposed to a mass. The presence of a mass would certainly suggest an invasive component.
Thank you. And what's your preferred approach for diagnostic procedures when you see a routine screening mammography like this that's suspicious? What would be the next processes? How do you go about getting tissue?
Sure. The next step after a diagnostic evaluation with magnification views would be to perform what's called a stereotactic biopsy, which allows us to target these calcifications with mammographic guidance and sample them to submit for pathology.
Thank you, Dr. Butler. As mentioned, she did indeed undergo a stereotactic biopsy revealing the diagnosis of ductal carcinoma in situ. I'm going to turn over to Dr. Mamounis now. What would be your discussion with this patient? Again, a 65-year-old, no family history, limited calcifications. Do you think she's an appropriate candidate for a lumpectomy? Obviously, that was the approach that she underwent.
Yeah, I mean, I think that with this limited presentation of microcalcifications and no family history and her age group, and the diagnosis of, at least on the biopsy here, low-grade ductal carcinoma situ is a very good candidate for breast conservation. We will discuss breast conservation with or without radiotherapy, depending on the final pathology. And obviously, we always discuss the alternatives of mastectomy, but certainly there is no particular reason for somebody like this patient to undergo mastectomy, given that she can easily undergo breast conservation. Sometimes we also, and maybe Dr. Butler can chime in, talk about breast MRI as a guide to define the extent of disease. But if the breast is fairly fat replaced and this is easily identifiable, not everybody needs an MRI. But maybe Dr. Butler can comment on that if she would like.
Dr. Butler?
Certainly. Yes, I'd be happy to do that. We are more and more selective about the patients in whom we use MRI for preoperative assessment of the extent of disease. As Dr. Mamounis said, not every patient with newly diagnosed breast cancer benefits from MRI, and MRI sometimes results in false positive findings that require further investigation, including additional biopsies, and potentially delay the time to surgery. For low-grade DCIS, I don't believe that MRI would be particularly helpful. Low-grade DCIS is sometimes occult on MRI, but it is quite well seen on mammography as it presents with calcifications, in particular in patients who don't have very dense breast tissue, but even in patients who have dense breast tissue, calcifications are seen quite well. So I think in this patient, a preoperative MRI probably would not add any significant information to the preoperative evaluation.
Thank you, Dr. Butler. Back to Dr. Mamounis. What would be your preferred approach to localizing this abnormality at the time of surgery? Obviously, she doesn't have palpable disease. We're going to need some way to guide the surgeon to the correct area of the breast. Can you explain to us how you would approach this?
Yes, and obviously, the radiologist always puts a radiopaque clip in the area of the calcifications, because sometimes even if there's a small area of calcifications, most of them, if not all of them, sometimes can be removed by the stereotactic biopsy. So we use the clip as a guide. Traditionally, we approach this with a wire localization. We put a wire to guide us to the clip. More recently, many are now switching to wireless localizations, depending on your preferred approach. At our institution, we like to use the SavvyScout approach, which is a radiofrequency chip that we then introduce a couple of days before the surgery into the area where the clip or the lesion is, and then use a radiofrequency probe to identify the area. It gives us also a guide in terms of how far from the radiofrequency chip we are. So we actually adjust our margins of resection based on the distance from the radiofrequency chip. Others can use radioactive seeds. There's magnetic seeds as well that you can use. So there's several wireless techniques that you can localize. And one of the advantages of that is sometimes it decongest sort of the ability to start cases earlier versus having to do all the wire localizations in the morning and then get your cases later in the OR. And it's much easier for the patient also to come at their leisure at a different day, get the wireless chip or radioactive or magnetic seed, and then proceed with surgery. So that's what would approach it.
Do you do specimen radiographs intraoperatively, Dr. Mamounis, to determine the extent of resection?
Yes, and that is actually something that has kind of changed a lot, our approach to intraoperative assessment for margins and for lesion excision. We have intraoperative imaging techniques where we take the specimen and immediately take a picture. We can, within seconds, find out if the lesion was excised. Obviously, with the radiofrequency chip, you know that it is excised because you can, get the probe on the specimen, you know it's there, but then you confirm that. And we also use that actually to assess margins. We'll take two orthogonal views of the specimen. And if you see calcifications at one edge of the specimen, you can obviously remove additional tissue. So that has been a big change in terms of how we assess margins. We used to sometimes, obviously for DCIS, it's not something that the pathologist will see anything intraoperatively, but for invasive cancer, sometimes we did intraoperative assessment for margins by the pathologist. But nowadays we rely mostly, at least in our institution, we rely mostly on the intraoperative X-ray for completion of lesion excision and to verify that the clip and the radiofrequency chip and everything is there.
And this patient did not have a sentinel lymph node procedure, of course, because they had non-invasive disease. Do you agree with that?
Yes, if there are no particular reasons to suspect invasion, as is, for example, a sizable palpable mass for DCIS or evidence of sort of microinvasion or suspicious microinvasion in the core biopsy specimen, then if you do breast conserving surgery, you always have the option to return to the OR and do it later on if microinvasion or invasion is demonstrated in the final specimen. And the majority of these patients will not need sentinel biopsy. So we always discuss that with the patient and we defer until we prove if there is microinvasion or invasion. It's a little bit different for mastectomy patients. For those, we actually recommend sentinel lymph node biopsy that on mastectomy because you don't have that option to do that later.
Thank you, Dr. Mamounis. Turning to Dr. Shaw now. This is a lady, again, just in summary, a 65-year-old with on final pathology, intermediate grade DCIS, negative surgical margins. Would you offer this person postoperative radiation?
So in thinking about radiation therapy, the first thing I would do is really have an evaluation of the patient, her performance status and her comorbidities. In a 65-year-old with DCIS that's ER positive, if she had a lot of comorbidities or poor performance status, that would move me away from offering radiation therapy. If, however, she was healthy and in good performance status, I think we talk about a few options. The first thing we would note is that radiation therapy in this situation is unlikely to impact her survival. And so the three options we would consider is omission of radiation therapy, whole breast radiation therapy, and partial breast radiation.
And do you sometimes use biomarkers to help guide your radiation decision? There are obviously two, I guess, FDA-approved approaches with genomic health, DCIS score, and also a prelude DX type of molecular assessment of favorable and unfavorable ductal carcinoma in situ.
You know, it is something that we discuss with our patients, and we do have one of those tests available on our registry trial. So it's something that we do discuss as an option to help potentially risk stratify those patients that would benefit from radiation therapy as opposed to those that would not.
And if you did offer radiation, would you be biased towards a partial breast approach or a whole breast approach? And if you were to treat with a whole breast, what would be your fractionation schedule? Would it be a 6-week therapy, 3-week therapy, 4-week therapy?
So in this patient, I usually talk about both options in terms of partial breast and whole breast. I do note that very few of the randomized trials included DCIS, though the current guidelines do allow for it. When it comes to whole breast radiation, I really typically in this type of case offer two approaches. The first would be hypofractionated whole breast, giving 40 gray and 15 fractions over 3 weeks. I do not recommend boost in these cases that are ER positive DCIS, age 65, negative margins. The other whole breast regimen I offer is based on the United Kingdom, and it's basically 28.5 gray and 5 fractions of whole breast given once a week for 5 weeks. Many of my patients 60 and older very much like this regimen.
We've come a long way in radiation from that 2 months worth of treatments now to potentially down to 1 week in treatment. Do you counsel the patients that they're relatively well tolerate this approach, or are there significant toxicities associated with this approach?
Yeah, so typically speaking, when it comes to whole breast and partial breast, we'll talk about side effects like breast erythema, breast edema, as well as long-term changes, including hypopigmentation, as well as long-term side effects like cardiopulmonary side effects. But I think with the advent of these very short schedules, the use of cardiac sparing techniques and partial breast irradiation, we see very little side effects, very low rates of even grade 3 dermatitis anymore.
Thank you. Dr. O'Shaughnessy, what's your discussion with the patient regarding adjuvant endocrine therapy?
So there are two agents that have been well studied in the context of lumpectomy, radiation therapy for DCIS, tamoxifen, and anastrozole. And the NSABP B35 really showed superiority of anastrozole over tamoxifen, but it was particularly in women under the age of 60, interestingly. But the thing is that tamoxifen has side effects in older women in particular that I think become sort of unacceptable in the context of risk reduction, because there'd be no impact on her survival with risk reduction endocrine therapy here. So I would talk to her about anastrozole and avoid the deep vein thrombosis, endometrial cancer, very small risk of stroke with tamoxifen, and talk to her about anastrozole. And it's for 5 years. But it would really depend on her overall performance status, lifespan, comorbidities. For example, women who are frail and at risk for falling, that can be exacerbated by aromatase inhibitors. Patients who are already osteoporotic, perhaps they've had an osteoporotic fracture, et cetera, that can be worsened with anastrozole. But I would tell her that there would be about a 1/3 reduction in the risk of a recurrence in her breast that would be invasive, and about a 50% reduction in her risk of getting a second primary DCIS or breast cancer. For women who have family histories, then their risk is higher of getting a second primary DCIS or breast cancer. So many times women will want to go in that direction. Many women, choose not to have endocrine therapy because of the side effects, of it. But I generally speaking, lean patients who are otherwise healthy, who have a long lifespan, I generally lean them towards anastrozole because I think the safety is in general very, very good. And I usually quote, for a woman who doesn't have a family history, I usually quote them about 0.5% per year risk of getting a second primary breast cancer. So that's about 10% or so through age 85, and a woman will have to look at that and see what she thinks. But that's reasonable for risk reduction. And then this woman's risk of an in-breast recurrence really should be very small with this grade 2 nuclear grade, clear margins, particularly if she accepts radiation therapy. If she did not want to accept radiation therapy, then I would be more inclined to more strongly encourage her to take the anastrozole. But it really requires, these are very long conversations because of the side effects of the aromatase inhibitors. From vaginal atrophy to osteoporosis to joint stiffness, hot flashes. And so women really have to understand all of that and really make a balanced decision.
Thank you, Dr. O'Shaughnessy. Just in summary, in that case, we would be recommending consideration of both either whole or partial breast radiation, in addition to a discussion at least about an aromatase inhibitor. So thank you to the panelists.